Okay, so the last topic that we will cover today before our lunch break will be ultrasound-guided foot interventions. Now, ultrasound is nice because you can often do image-guided needle intervention in the same setting even as the diagnostic evaluation. And that gives ultrasound a significant advantage of many other imaging techniques. There are many different techniques valid for ultrasound for intervention of the foot, and in general, as has been mentioned by both Drs. Southam and Edmonds, if you can see it and you can safely get there, you're going to be fine, and this is definitely true in the foot. In this lecture, we're going to discuss injection of the Morton's neuroma. We'll discuss a couple of toe injections using a small joint technique that I will show you that's a little different perhaps than has been presented, that I like. If you have a large transducer, you can still do efficiently in a small joint. We'll briefly discuss aspiration of abscess and fluid collection and a couple of other things. So, as Dr. Southam talked about, Morton's neuroma. Now, this is a common cause of forefoot pain and paresthesia. It's been described since the mid-1800s. It's thought to be due to compression of the common plantar digital nerve under the transverse metatarsal ligament. And on this short axis MR image, you can see the transverse metatarsal ligament demonstrated by the red arrows, and underneath them the common plantar digital neurovascular bundle. It's easy to perceive that in the process of stepping or running, this may be compressed, and that you may develop fibrovascular inflammatory tissue around that nerve. That's what a Morton's neuroma is. Here's an MR example of a Morton's neuroma. This is an intermediate weighted TE proton density sequence. So the Morton's neuroma is intermediate in signal intensity. I'm pointing at it with the arrow, but there it is outlined in red. I'm going to go back. There it is outlined in red, this teardrop-shaped mass, which is essentially a scar ball around the common plantar digital nerve within the web space. Histologically, it's characterized by perineural fibrosis, endoneurally edema, axonal degeneration, and local vascular proliferation. Now, sonography is sensitive and specific in diagnosis of neuroma. Dr. Southam showed you a short-axis ultrasound image, very analogous to this MR image, showing you the teardrop-shaped mass in the web space. In the long axis, you can image it in this way. You put the transducer in the long axis of the foot on the plantar side and use your fingers to press the tissues toward the transducer from the dorsal side. This has the dual advantage of separating the bones and pushing the neuroma into your transducer, and giving you also the ability to see if the material in there compresses or not, if there's a bursa or a neuroma. In so doing, you'll end up with an image much like this. At the level of the joint, you have the proximal phalanx on the left, metatarsal head on the right of the image. You can see the plantar plate as I've shown by the red arrow, and the flexor tendon over the top of it. That's at the level of the joint. Move over into the joint space and you press it, and in a normal joint space, you can see this is the first web space. You just have a bunch of fatty tissue. It doesn't look like you're looking at anything. This is what a neuroma would look like in the web space, an oval-shaped isoechoic to hypoechoic mass, in this case surrounded by a little more hypoechoic to anechoic bursal tissue. And the reason that it doesn't look like that there's any other tissue around is because you're right in the web space on a long axis view. If I move just over slightly more, I'll be at the next joint, and I can move over into the next joint space. So again, I start at the joint, find all my structures in the joint, then move into the web space and look for the little hypoechoic mass within the web space. That's the long axis method to find that neuroma. Okay, now how am I going to inject the neuroma? There's various ways to inject it, and I'll get to that in a second. First of all, a single ultrasound-guided injection of Morton's neuroma using a corticosteroid mix about 3/4 of those will be asymptomatic after 7 days, after the first week. So in the short term, you have good pain relief. What about in the long term? A variety of different things have been utilized for injection of Morton's neuroma. Some researchers have tested a series of corticosteroid injections. They had good pain relief at 2 years. Another group utilized a similar series, but they used alcohol for their injections, and they also had very good pain relief after 2 years. So in the long term, either corticosteroid or alcohol with a series of injections, you'll be able to get good pain relief. You can approach the Morton's neuroma from a dorsal needle approach, from a plantar needle approach, or the method that I prefer here is to just go straight down the web space in the long axis of the foot. In general, I have found that if you put the ultrasound transducer on the plantar surface, you will have a tendency to put your needle more toward the plantar surface. It seems to be a little more tender for the patient to have the needle stick there. So when I can see it, if I can see it with the transducer on the dorsal surface, I'll put it there. It seems to be easier to get my needle into the web space where I need it and better tolerated by the patient. It's harder to see the neuroma from the dorsal approach with your transducer. As long as you can see it, you can get your needle into it. Again, here's that long axis view of the web space. Doesn't look like there's anything around it. It's like, what am I looking at? There's this oval shaped thing in a sea of fatty tissue. You're in the center of the web space in a long axis image. There's your neuroma. I thought I was going to outline it. There we go. There's your neuroma outlined in red. It is, in this case, also surrounded by a hypoechoic bursa. We're going to go through the web space. That will have the needle coming basically right from the side of your screen or the side of your field, and you stick it right into the neuroma. You test inject, if necessary, some local anesthetic, and then when you inject the corticosteroid mix, it looks like this hyperechoic, irregularly shaped material coming out of the needle tip. Common mixtures for a corticosteroid mix for a neuroma. We do Kenalog 40. We do a half a cc, so that's 20 milligrams of Kenalog with a half a cc of bupivacaine. And there are some possible complications for that from the steroid, which include plantar fat pad atrophy, dermal thinning, and hyperpigmentation. That is a small minority of cases that will have those complications, but be aware that those can occur from this type of injection. Common alcohol mixture, if you prefer to try that, would be 0.1 milliliters of 100% ethyl alcohol and 0.4 milliliters of bupivacaine as the mixture. And common reported complications from that include fat necrosis, localized inflammation or fibrosis, and in rare cases, complex regional pain syndrome. All of these complications are very unusual. This is typically a very safe procedure to perform. It's important to inject directly into the neuroma to try to avoid leakage into the surrounding tissues, because that's what kind of can give you the complications. Now, moving away from that, I'm going to describe a small joint access technique, which we have found very useful. We've talked fairly extensively about intra-articular steroid injection, and so I'm not going to get into it in great detail. Again, it is useful for both diagnostic and therapeutic treatment and evaluation of osteoarthritis, inflammatory arthritis, or synovitis. And here's a case with an osteochondral lesion of the first metatarsal head at its medial aspect in a patient who's had a bunionectomy. And we talked about some of the potential risk of chondrolysis from these local anesthetics and corticosteroids, so I'm not going to get into that in great detail right now. Okay, now if you have a small footprint transducer, these are typically high resolution, around 15 megahertz. They're very useful for small joints, and I recommend them. However, you may not have that depending on where you're located. In a deployed environment, you certainly don't have the option to choose what your equipment is. So I'm just going to show you an efficient technique with a large transducer that you can do on a small joint. So this is a large, high resolution but large footprint transducer. For this technique, what you'll do is you'll start in the long axis of the toe or joint. You're looking for the joint space. So again, as Dr. Edmonds mentioned, you're looking for the transition of the cortex. And this is the corresponding long axis MR image showing you what you're going to see on the joint space. On the ultrasound, you see the transition in the cortex between the metatarsal head. Yellow arrows are showing you that hypoechoic articular cartilage. There's the transition showing you the joint space between the metatarsal head and the proximal phalanx. Once you've found that joint space, put it in the center of your probe, and now turn your probe transverse on the joint. And when you do this, you're going to see, if you bring it back onto the metatarsal head, you'll see the cortex looks rounded of the metatarsal head. As you move it distally into the joint space, that cortex will disappear. So you start with cortex, you get to the joint space, the cortex disappears. If you go past the joint space, you'll see cortex again. So it looks like you're at an image where you don't see anything, and that's because you're in the joint space. You know that because you started in the right spot, and you started at the cortex, and you just went past it to where it disappeared. Okay, so now that's your target. We're going to go from either medial or lateral dorsal approach, freehand technique. I'm showing you with a spinal needle. In all cases in the toes, I will use a small 25 gauge needle. This photograph we took for demonstration purposes. As you move from a dorsal lateral approach, in this case, you put the needle into the joint space. Remember to keep your transducer in the spot where you don't see that cortex, so you know you're in the joint space, and you can guide your needle right into the joint space. That's what it looks like initially as you place the needle. Now you leave the needle there, you turn your transducer the opposite direction, and you look for the needle tip right in the center of the dorsal aspect of the joint space. Now you see, once you see that needle tip there, you can attach your syringe and test inject, and you'll watch that capsule lift off as you test inject. You know for sure now that you're in the joint, and you can perform your injection or your aspiration. So it's a fairly simple technique to use a very large footprint transducer for a small joint effectively. Okay, and there's your needle tip still in the joint space there. Now this is an example from not too long ago from here at Wilford Hall. A patient, basic trainee, came into the ER with toe pain. We noticed some erosions in the joint from a previous radiograph, which I've not shown you. The joint space had mildly decreased. We were worried about a septic joint. We called them. We said, get them over here. We'll take a look with the ultrasound and see if there's fluid in there, and if there is, we can tap it. So we brought the patient over, and sure enough, on the ultrasound, on the left, you've got a long axis image. You've got metatarsal head here and proximal phalanx here. And you've got a distended dorsal recess of the joint with intermediate echo synovial tissue within the distended dorsal recess. On the short axis image, you see that curvilinear cortex and the distended dorsal recess, again with internal echoes. Okay, now having seen that, we placed our needle from a dorsolateral approach into that joint space. Again, we are at the joint space, I know, because I don't see that curvilinear cortex now. There's my needle tip. As I turn transverse, there's my needle tip within the joint. As we began to try to, once we actually got the needle into the joint, it was under pressure, and this purulent looking fluid came out. When we sent that, it actually turned out to be monosodium urate crystals. It was not a septic joint. A very interesting case. Okay. So this is essentially the same process. I'm just going to show you in a midfoot joint, so we don't have to spend as much time with this one. We're going to find the joint that we're looking for and look for that transition in the cortex to know whether we're at the joint space. We're going to go transverse on it, going to find where we lose that curvilinear cortex at the dorsal margin. Put our needle in. We now place the needle right into that joint space. It looks like you're placing the needle into just nothing, really. It looks like you're just placing it into fibrovascular tissue, but you know you're in the joint space because of all your preparation that you've performed. Turn transverse on it. Now you see the needle tip in that transition spot between the two bones in the joint space, and injection is going to lift that capsule up, and further injection lifts it up further and further, and that's still our needle right there in the joint space. So it's a nice technique for any small joint in the hand or foot. Okay, this has been discussed earlier, and I know there's a little bit of overlap between the ankle and foot. I'm just going to mention it briefly. Plantar fascia, the most commonly reported cause of chronic heel pain. In the majority of cases, these are initially treated conservatively. If you place the ultrasound at the long axis of the foot at the level of the heel, you can see that echogenic cortex and that thin echogenic normal plantar fascia in this case, and an abnormal plantar fascia in this case, where it is very thick, it is heterogeneous in its fibers. In this case, you've actually got interstitial splitting, and so a clear case of plantar fasciitis. If you're going to compare it to the MRI, again, you can see the edema. You can see the soft tissue edema adjacent to it, thickening of the plantar fascia, interstitial splitting. And if you go short axis on it, it will look like this oval shaped thing with thickening, and you can see the interstitial split. I'm going to go one slide back. Ultrasound has similar accuracy to MRI for diagnosis of plantar fasciitis. It has actually been shown to be slightly superior for diagnosis of plantar fibroma. Okay, for injection of the plantar fascia, as Dr. Edmonds mentioned, there is a fair amount of literature out there on injection of the plantar fascia. Most of it is advocating direct injection, intratendinous injection within the plantar fascia. Certainly this does increase the risk of plantar fascia rupture. We try to avoid that. We know from some other literature that I presented yesterday in the biceps tendon that if you perform intratendinous injection, you can have some necrosis of corticosteroid. You can have some tissue necrosis within it. So rather, we're going to perform a peritendinous injection of plantar fascia. I usually have the patient prone with the leg hanging off the table, as Dr. Edmonds showed. I go long axis of the foot with the needle, and I put the needle right at the adjacent to the plantar margin of the plantar fascia, and here's the injected fluid after the test injection, showing the location right along the plantar fascia. Perifascial injection does allow relief of pain and inflammation and less risk of plantar fascial rupture. There's our needle right by the tendon, or by the plantar fascia. As in any body part within the foot, we may be asked to diagnose and or treat a soft tissue abscess. Ultrasound is very good for finding this kind of thing. In general, it will look like a complex hypoechoic fluid collection, and on Doppler you will often have hyperemia in the periphery of the collection, as you can see in this case of a soft tissue abscess adjacent to the third metatarsal. This is very easy. You can see the target. As long as you can find a safe access route to get it there without a neurovascular bundle in the way, you're going to be fine, and you can easily get, it's a chip shot to get the needle into that abscess and aspirate. Ultrasound is particularly suited for this kind of thing because of the real-time evaluation or visualization of the needle and the ability to visualize the soft tissues and the fluid collection as well. And that needle procedure can be performed in the same setting as the initial diagnostic evaluation if you're prepared for it. There's our needle going into that abscess, and on the bottom image it's much smaller after the aspiration. It's interesting that Dr. Southam showed a stress fracture, as you'll see in this case. Sometimes you're asked to look at something on ultrasound, and you're in there and you're talking to the patient, and this is what happened in this case. The patient was sent to me to look for a perineal, to perform a perineal tendon sheath injection. As we looked at the perineus, longus, you can see marked tendinosis and a complex tear of the tendon. Here's the long axis view. You can see the peroneus longus markedly thickened and heterogeneous as you come in. Then there's the location of complex tear. This is a portion of the stump of the peroneus longus tendon. So already we were kind of not really wanting to do a peroneal tendon sheath injection, but in the process of the discussion, the patient said, well, wait a second, doctor, that's not where it's hurting now. He said it used to hurt there, but that's not where it hurts now. Okay, where does it hurt? He showed me pointed to his midfoot at about the level of the fourth metatarsal. Okay, so I just went ahead and put the ultrasound transducer there, not knowing what I would find, but just to see what I would see. And the fourth metatarsal phalangeal joint looked normal, but we found this cortical discontinuity and some periosteal elevation along the shaft of the fourth metatarsal. And so as we discussed it became clear that he had pain from his peroneal tendons, and he had changed his gait patterns, and we suspected that he had developed a stress fracture. We sent him for radiographs, and sure enough, there's his stress fracture. So it's an interactive session with the patient. Please listen to your patient. Be cognizant of other things that can occur as a result of the situation that's present, and do your best to try to see it. You may see more than you realize, and in the setting of fracture, ultrasound, no, you can't see the meroedema pattern, but you can see the cortical discontinuity, and you can see the periosteal elevation with very high resolution. So take a look, see what you can see. You may not be able to make the diagnosis, but you may be able to help that patient and get them to the appropriate treatment that they need. Okay, so in summary, ultrasound is a useful tool for performance of imaging diagnosis and image-guided needle procedures in the foot. The high-resolution imaging of ultrasound, the real-time visualization of ultrasound, the Doppler evaluation, the ability to perform dynamic evaluation, and the ease of access are all great advantages of ultrasound. Only a handful of procedures that I have presented as examples in this talk, which include neuroma diagnosis and injection, toe or midfoot joint injection, plantar fascia diagnosis and injection, and soft tissue abscess aspiration. We've not discussed in this particular talk tendon sheath injections. That's been extensively discussed within the ankle, and to be honest, ankle tendon sheath injections are much more common than toe tendon sheath injections. There are many other possible procedures that you can perform within the foot with appropriate planning, review of relevant anatomy, and preparation. Thank you.